Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy.
Right.
This episode reviews the article titled, Global Baseline Assessment of Migrant Responsive Health Systems.
And it's a really crucial topic we're covering today.
It really is. So to kick off this deep dive, I want you to imagine, just for a second, that you are standing in a crowded room.
Okay.
Maybe it's a busy subway car during your morning commute, or a packed coffee shop, or even just a large family gathering. Now look around that room and count to 8.
Just 8 people.
Right,
Yep.
because for every 8 people you see, statistically speaking, one of them represents a massive, invisible, global movement.
Yeah.
1 in 8 people on this planet right now lives as a refugee or a migrant.
Which is just a staggering number when you really think about it.
It is. That is over 1 billion people globally. And that's really the core of today's deep dive. We are looking at a massive paradigm shift in global health, specifically how countries are fundamentally restructuring their systems to treat the medical needs of this incredibly mobile population.
Right. The central research question essentially is how systems adapt to that mobility.
Exactly. We've pulled a stack of recent sources to guide us today, primarily news releases from the World Health Organization, the WHO, and of course that April 2026 report published in the Georgian Medical Journal. Our mission today is to unpack this first ever global baseline report on migrant responsive health systems, understand the structural progress being made, and expose the critical operational gaps that still leave millions vulnerable.
Yeah, and, contextualizing that 1 billion figure is really the necessary starting point here.
Yeah, definitely.
Because when you visualize it in that crowded room, like you said, it stops being just an abstract statistic on a page. It becomes a profound reality of the human experience.
Right, it makes it tangible.
Exactly. Human migration is a defining feature of our shared history. It's not some anomaly. People are moving for a vast array of reasons.
Like fleeing conflict, right?
Right. Conflict, escaping the escalating impacts of natural disasters, or, simply crossing borders in pursuit of economic opportunity or education or family reunification. And the conceptual background here is that national health systems were largely built in the 20th century for static populations, people who stay in one place.
Yeah, you live in a town, you go to the town doctor.
Exactly. But today, those systems are being forced to adapt to a world that is constantly in motion.
And that friction between static systems and a highly mobile population is exactly what the new WHO data eliminates.
It really does.
Here's where it gets really interesting, though. The baseline report draws on 93 member states, and it reveals that over 60 of those countries, so roughly 2/3 of the ones surveyed, now explicitly include refugees and migrants in their national health policies and laws.
What's fascinating here is that establishing a global baseline is really a watershed moment for health policy.
How so? I mean, hasn't the WHO always tracked this stuff?
Well, actually, no. For decades, the health status and the systemic inclusion of migrants have been treated as sort of a black box.
Oh, wow.
Yeah, a country might have had piecemeal programs run by non-governmental organizations or charities, but there was no standardized metric to track who was doing what on a structural level.
Everyone was just kind of flying blind.
Exactly. And you cannot fix a systemic flaw that you do not measure. This baseline finally gives the global community a yardstick to track actual progress, measure policy adoption against real-world outcomes, and, move beyond guesswork.
That makes total sense.
Yeah.
Because building a national health system that ignores 1/8 of the population is, well, it's basically like building a highly secure corporate computer network, but intentionally leaving 12% of your employee laptops without any antivirus software.
That's a great way to put it.
Right. Like the virus doesn't care about the safe laptops. It just uses the unprotected ones to compromise the entire system.
Exactly.
In the realm of global health, pathogens, chronic diseases, and resource strains, they don't respect immigration status.
No, they don't. And that analogy captures the mechanical failure perfectly. And it points to a broader shift in how health ministries are approaching this issue now.
Which brings up a question I had while reading the sources. Is this shift happening purely out of humanitarian goodwill? Or is there a practical systemic realization driving this?
Oh, it is heavily driven by a practical, systemic realization.
Okay.
While humanitarian principles are always part of the conversation, of course, the sources emphasize that historically, health systems have categorized migrants and refugees merely as recipients of care.
Like they're just burdens draining resources.
Right, exactly. But we are now seeing a structural pivot toward recognizing these individuals as health workers, as caregivers, and as community leaders who actively sustain the system.
Oh, interesting. So they're contributing, not just taking.
Exactly. And if we connect this to the bigger picture, health ministries are seeing a massive return on investment. The report outlines these as far-reaching dividends.
Right, because keeping people healthy is cheaper than treating them when they're critically ill.
Precisely. Inclusive systems reduce long-term costs through the basic economics of preventative care. When a marginalized group is excluded from primary care, they don't stop getting sick.
No, they just wait until it's unbearable.
Right. They delay treatment until a minor, easily treatable issue becomes a full-blown medical emergency. Treating a severe infection in an intensive care unit costs a health system exponentially more than a basic clinical visit and a course of antibiotics.
That makes total sense from an economic standpoint.
Furthermore, keeping these populations healthy prevents the spread of communicable diseases and enables them to contribute fully to the local economy. Universal health coverage only functions as a protective network when it serves everyone within a geographic boundary.
Yeah, the sources actually provide some really compelling case studies of countries leaning heavily into this public health data. Thailand, for instance.
Oh, Thailand is a fantastic example.
Right, they have actively expanded migrant health insurance coverage. They basically ran the economic math and realized that getting people insured and into the primary care system is far safer and cheaper than dealing with a shadow population entirely cut off from the medical grid.
Yeah, Thailand is really demonstrating the operational shift from a reactive emergency room model to a proactive public health model. Insurance provides a mechanism for early intervention, which stabilizes both the patient's health and the hospital's budget.
And then we have Belgium, which I found fascinating. They are utilizing cross-cultural communication mediators.
Right.
And this isn't just about handing out a translated pamphlet, right?
No, not at all.
A cross-cultural mediator is a professional who explains not just the language, but the cultural context of a diagnosis.
Exactly, because if a doctor prescribes a treatment that conflicts with a patient's cultural understanding of medicine, the patient simply won't comply.
Right, leading to wasted resources and repeat hospital visits. So the mediator prevents those costly misdiagnoses by bridging the cultural gap in real time.
That nuance is critical. Language translation is a technical fix. Cultural mediation is a clinical necessity.
I love that distinction.
And the same principle of deep integration is happening in Chile, where they are explicitly including migrant community representatives in the actual decision-making processes for how primary health care is delivered.
So instead of a board of administrators just guessing what a migrant community needs, they have representatives sitting at the table saying, here is the actual barrier our people are facing at the clinic doors.
Yes.
It's the fundamental difference between doing something for a community versus doing something with a community.
And that operational transition from a written policy to actual implementation is the hardest part of health governance. Chile, engaging migrant representatives, ensures that the services designed are actually effective and culturally resonant rather than just, well-intentioned.
Okay, let's unpack this a bit more. Because if the ROI is this clear, and countries like Thailand, Belgium, and Chile are already proving the mechanics work, what is the bottleneck preventing the other 60 countries from executing it? Because the WHO report makes it very clear that having a policy on paper does not magically fix the reality on the ground.
No, it doesn't. The bottleneck is the massive execution gap. The structural and methodological considerations in the report highlight a severe disconnect between policy design and operational reality.
Right.
For instance, only 37% of the responding countries routinely collect, analyze, and disseminate migration-related health data as part of their national systems.
Wait, really? Only 37%?
Just 37%.
If only 37% of these countries are actually collecting data, how do the other 63% even know if their inclusive policies are functioning?
They don't.
Like, how does a hospital allocate budget for migrant care if the administrative software doesn't even have a mechanism to track those patients?
They don't. And the operational failures just cascade from there. Only 42% of countries include refugees and migrants in their emergency preparedness or disaster response plans.
Wow.
Fewer than 40% actually report training their health workers in culturally responsive care. And just 30% have implemented any sort of communication campaigns to counter the discrimination and misperceptions surrounding migrant health.
Well, let me push back on the framing of this entire report then.
Sure.
If fewer than 40% of these countries are training their doctors and nurses to implement the care, aren't these national policies largely just lip service?
That's a very fair point.
I mean, it seems incredibly premature to celebrate 60 countries adopting inclusive policies if frontline workers have no idea how to navigate the cultural nuances of their patients, and the hospitals aren't tracking the outcomes.
That is a necessary critique. A policy without funding, without frontline training, and without robust data collection is merely a statement of intent.
Right.
But the WHO is highlighting the establishment of legal frameworks because that is the mandatory first step. You cannot fund a program that doesn't legally exist.
Okay, that makes sense. You need the foundation first.
Exactly. However, you're right to be skeptical because the phrase inclusive policy often acts as a blanket term that hides profound, uneven access.
Oh, so?
The report notes that while officially recognized refugees might have a relatively clear, legally defined pathway to accessing health services, other groups fall completely through the cracks.
Meaning access depends entirely on the specific documentation you hold.
Yes. Migrants in irregular situations, internally displaced persons, migrant workers, and even international students are far less consistently covered.
Oh.
They are systematically excluded from the data pools and remain severely underrepresented in health governance globally. That disconnect between legal aspiration and clinical reality is exactly why the international community is trying to urgently pivot toward operational execution.
Okay, so if physical infrastructure, worker training, and paper documentation are failing these mobile populations so drastically, the solution logically has to travel with the patient, right?
Precisely.
The sources outline a specific roadmap of accelerated actions urged by the WHO, things like embedding migrant considerations into all national health strategies, forcing cross-sector coordination with housing and education. But the most fascinating leap is happening on the digital frontier.
Yes, the digital aspect is huge.
The International Organization for Migration, or the IOM, recently became the first international organization to officially join the Global Digital Health Certification Network, the GDHCN.
And this raises an important question. How do you maintain continuity of care for people who are constantly moving? The GDHCN addresses the core logistical nightmare of human mobility. When a person is forced to move, their medical history is almost always left behind in physical filing cabinets or localized closed-loop server systems.
Right.
The GDHCN is a WHO-hosted digital public infrastructure designed to enable the verification of health documents across different national borders.
Anyone who has ever tried to get their own dental records transferred to a new clinic across town knows it is an absolute administrative nightmare.
Oh, it's terrible.
You are filling out forms, making phone calls, waiting weeks. Now, imagine trying to do that across 3 international borders in a language you don't speak while actively fleeing a crisis.
It's nearly impossible.
You arrive at a new clinic, and the doctor has to start completely from scratch. They don't know your allergies, your chronic disease management history, or your vaccination record. It is dangerous for the patient and incredibly inefficient for the host country's medical system.
And the friction in that scenario is exactly what the GDHCN is designed to eliminate. By the IOM joining this network, it signals a collaborative effort to help migrants securely access verifiable health records wherever they go.
Right.
And it functions securely without requiring 2 different countries to completely merge their private healthcare databases, which would be a privacy nightmare.
Yeah, nobody wants that.
Instead, it uses cryptographic verification, essentially a highly secure, universally recognized digital medical passport.
So it verifies the authenticity of the medical data without compromising the patient's privacy.
Exactly.
The patient holds the verified record, and the new doctor can instantly trust the data.
It empowers the individual patient to own their medical history, while simultaneously relieving a massive administrative and diagnostic burden from the host country's health system.
That's brilliant.
Ensuring continuity of care across borders is rapidly becoming a foundational pillar of global public health. The future of health security relies on trusted, interoperable digital systems that can keep pace with mobile populations.
So what does this all mean? We have covered a vast amount of ground today, so let's recap the core system-level reflections of this deep dive.
Sounds good.
We started by contextualizing the massive scale of human movement. 1 billion migrants globally, representing 1 in 8 people on Earth. We examined the structural progress of over 60 countries finally putting inclusive health policies on the books, driven by the undeniable economic and security dividends of preventative care over reactive emergency treatment.
Right.
We confronted the reality check of the execution gap. The critical, persisting shortages in data collection, worker training, and emergency prep that leave millions in irregular situations vulnerable.
Yeah.
And finally, we unpacked how digital infrastructures like the GDHCN are attempting to solve the continuity of care crisis by giving mobile populations secure, verifiable ownership of their health records.
And seeing this baseline established gives health ministries, policymakers, and frontline workers a map to navigate the systemic flaws moving forward. You have to start somewhere.
Exactly. And before we wrap up, I want you listening right now to consider your own community's health infrastructure.
That's a great point.
Think about the local clinic down the street or the primary care hospital in your city. When a new family arrives in your community, maybe from another state, maybe from across the globe, what invisible barriers are they facing when they walk through those sliding glass doors? Is there a language barrier that lacks a cultural mediator? Is there an administrative software system that refuses to intake them without a specific type of documentation? Understanding global health always starts with questioning the systems operating right in our own backyards.
To build on that perspective, I want to leave you with a final thought to mull over.
Okay.
We have discussed migration today largely in the context of our current geopolitical and economic world. But as climate change accelerates and global economic shifts continue to disrupt traditional industries, human mobility is inevitably going to increase over the coming decades.
That's undeniably true.
Eventually, the line separating migrant health and standard public health is going to completely disappear.
Wow.
The ultimate question becomes, will our digital infrastructures, our political willpower, and our cross-cultural training evolve fast enough to meet a world where being on the move is the norm rather than the exception?
That is a massive question and one we are all going to have to face sooner rather than later.
Absolutely.
Thank you for listening to the GMJ podcast.
It was a pleasure to be here.
For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description.
Right.
We look forward to continuing these scholarly discussions in future episodes.